Hello, my
So,
name
yeah,
Hello, my name is Eileen Davidson, and I'm here with a rheumatologist from India named Roy, and I'll let him explain himself a little bit more in a moment. But we're going to be talking about remission today. Roy, would you like to take the stage?
yeah. Hello, Eileen. Thanks for having me here. Talk about this very important aspect. So, I'm from India. So, I'm Debaditya Roy. I'm a budding rheumatologist. You can see I'm in my final year of residency in rheumatology from India. Currently, I'm based in Kolkata. That's in the eastern part of India, and where I'm doing my residency from institute called IPGMER. And like I love the subject. I love my patients, and I love to talk about it, engage more, and let's see how this chat goes. And I'm very eager to answer any of your questions and help out patients out there. Yeah.
Yeah. I'm trying to capture a global perspective on what remission is with rheumatoid arthritis. I've interviewed a variety of rheumatologists from different countries. You are the furthest away so far, so thank you for taking the time. And now I've noticed that you are incredibly engaged with patients on Twitter X the most.
Right.
I'm really interested to know what got you into rheumatology because you seem very passionate about it.
Yeah, see, this is something which, first of all, in India, you cannot directly engage and be a rheumatologist right after you do your MBBS. That's the first step of being a doctor. So you need to complete your general medicine or internal medicine, as it's called, globally, and then you can apply for something for a specialty course like rheumatology. So it's a special branch of medicine. So what attracted me to this part of the field was it kind of rheumatology doesn't deal with a certain organ of the body, so it's you have to actually know the human body in total. So rheumatology has its own puzzles to offer, and you need to be a very good clinician to pick up those clues. And I think the closest that I can be with medicine is with being me a rheumatologist. So every branch is a special one, every branch has something to offer, and I love what rheumatology has to offer, and I still am enjoying my every day of being one. Yeah.
That's really interesting because living with rheumatoid arthritis, I'm constantly trying to tell people rheumatoid
Right.
arthritis is so much more than just joint pain. It's not just one
Absolutely.
symptom. So it's really interesting that you brought that up as a reason why you wanted to become a rheumatologist.
Right.
All right. Okay. Well, we're going to shift the conversation a little bit about what is remission with rheumatoid arthritis. And is there like a one size fits all? How long does it last? And can somebody fall out of remission?
Right. So I think we can begin with your first question, that what is remission? That's a very important and interesting question to begin with. So we shouldn't confuse remission with cure. That is the first question that patients asks us when they visit us at clinic, that doctor, shall I be cured of this disease? And there's a kind of anxious look on their face, and when they come out, they are confused, they're anxious, they have an element of fear in their voice, and they don't know how this journey is going to be with. So I would like to say remission is something that we connect with chronic diseases. Rheumatoid arthritis is like a journey. So remission is a state of being not active with the disease. So the disease is in an inactive state currently, and it's something which all patients want to be in, a place, a safe place. Remission is a safe place to be in, but it's not a permanent state. You can fall out and fall in of remission anytime, and that's where a good rheumatologist comes into the play to help you in this journey. So remission is a state of inactive disease, that's in short. Yeah.
Is there like a range of how long it typically lasts for patients?
Absolutely. So before that, we need to understand that remission for a patient might be just the absence of pain, that you're not feeling pain in your joints, or you are not feeling fatigued anymore. So, but that's not what remission is all about. So remission, imagine remission like a pyramid. you know. So the base of the pyramid is what you call as clinical remission, what the patient feels and what we can observe, like the pain, fatigue gone. But that's not all. So there is a second layer of pyramid which is called the what lies underneath, that whenever we do the some imaging of the joints, suppose with a machine called ultrasound, so where there we can see that yes, it is still there, it is just sleeping away, it's not gone, it can wake up anytime. And the third part of the head of the pyramid is the immunological remission, that what tests are there, like the rheumatoid factor and other blood tests. So those needs to be come down, those needs to be negative. So in all, it's very difficult to say that you have achieved a complete state of remission just by looking at you clinically. So we can just observe and say that yes, currently the disease is inactive, but saying that you have complete every level of remission, it's difficult. But there are ways to do it. So I would suggest that first, definitely there are. It's very important that to have a good clinical examination with your rheumatologist. Patient should be engaged with these questions, that how they are feeling. It's not only pain. I think I would, you would agree with me, Eileen, that sometimes even if when the pain is not there, you feel a sense of fatigue, right? Right. Yeah. So this fatigue is something which can be connected to rheumatoid, which can be connected with something called fibromyalgia, which is often connected with rheumatoid, uh, which can be connected to a sense of uh, there's always maybe a chronic anxiety and an element of depression in these patients often, which might make them feel that they're having this fatigue. But we need to engage the patients. We need to appreciate all of their symptoms. We cannot just say to the patients that, oh, it's okay, you will be having this for a while, because every symptom is should be important to a rheumatologist. There are blood tests, like I won't go into the technical details, that will be pretty boring, but there are something called ESRs and CRPs, which we sometimes offer to the patients, just to be sure that we are giving them the right statement, that when we say that you are in remission, we see that these patients have no more any swollen or tender joints, their ESR and CRPs at a normal level. And if not all the facilities have this provision of ultrasound machine, but if you have them, you can use them to see whether the joints are showing any sense of type of inflammation in the machine or not. So if all you can tick off all these boxes, yes, you can say, yeah. So uh, uh, and like I would like you to ask me about whether we can predict remission or not. I think that's something very exciting to know, right?
Yeah, actually,
Yeah.
can you predict remission in patients now?
Yeah. So see, there's something called predictors of remission. We have so many good studies taking place all over the world, where they have kind of it's not a, you cannot say it's 100% foolproof system that you can, yes, predict remission 100%, but there are certain predictors which can indicate that yes, this patient is going to have a long lasting remission if achieved. So the baseline activity of the patient, how early are you starting the treatment of the patient, the age of the patient, the gender of the patient, the body mass index of the patient, the autoantibody status of the patient, whether the patient is seropositive or seronegative, and how long the last remission lasted. All these factors can predict you, helping a patient understand that how long will the current remission last. Yeah. So
Does,
these are some of the predictors.
yeah, does gender play a role in that at all?
Yeah, absolutely. So there's some studies which have shown that male gender usually have is considered a good predictor of remission. So although it's obvious that there is a women are more affected in rheumatoid arthritis and overall. Also, there are studies to indicate that male gender is more likely to achieve remission. But when a patient asks you, suppose a female patient, a woman comes to you and say, well, do my gender makes me fall into a high risk, or possibly I might not get remission as well as my male counterpart. So I think being a rheumatologist, we have to be sensitive, we have to be empathetic. We cannot just say, yes, you fall into a higher risk compared to your male counterpart. It's just not fair, because gender is just like just one of the minor factors that can determine your remission. It is no way it's going to play a major role. So uh, your engagement with the patient should be very careful. So gender, yes, plays a role, but a minor one.
Okay. What about lifestyle? Does that play a role in remission at all?
Ab- Absolutely, absolutely. So lifestyle is going to play a huge role, because it directly and indirectly affects your rheumatoid. Good exercise regime,
Hmm.
proper BMI, that's a body mass index, maintaining a healthy diet goes a long way to achieve your remission, and more importantly, sustain your remission. Whenever a patient achieves remission, uh, there's a kind of lapse often we see in the patient's behavior regarding the medications, regarding the lifestyle changes that he or she has adopted till now. But then again, all patients need to realize that remission achievement is just half job done. It's very important to take that remission further. And there are studies which have shown that if you can achieve 1 year of sustained remission, that is 1 year of being in an inactive state, then your chances of a longer remission increases. Yeah. So a patient who have somehow can take this remission to 1 year after the first when the clinician rheumatologist says that you are in remission, and she can take this 1 year from that date. She just increases the chances of a longer remission. And the problem is, it's also true that during this first year, the majority of the lapses happen, that whatever medications have been given to them, for whatever reason, there are various reasons, they either stop taking the medications or they start altering the medications of their own accord. And there lies the problem. And when you relapse, the number of times you relapse out of a remission, relapse as in you fall out of remission, you increase your chances of the increased activity more. It's either way around. So the longer you are in remission, you are doing yourself a great favor by increasing your chances. The earlier you fall out of remission, the more are your chances of prolonging your active state, the, the, equally in that phase.
That is that is very
Yeah,
interesting. I really appreciate how much you keep up with the research too. You seem to
right.
know a lot about that. Now you touched a little bit on this previously, but can somebody be in remission and still have symptoms like cognitive dysfunction, fatigue, or pain? And you did touch a little bit about some of the comorbidities that could be causing
Yep,
it. What are some of the comorbidities that are very common with rheumatoid arthritis that might
right.
halt somebody from remission or present as still showing symptoms?
Right. So, to your first part of the question, I would like to deal with the comorbidities part first, because that's very important to understand. The usual comorbidities which we face in our clinics usually are the hypertension, diabetes mellitus. We often have hypothyroidism. These are the usual comorbidities. Sometimes you see that a patient having coexisting comorbidity, any a patient, hypertensive patient with rheumatoid, you have to appreciate that he or she has to take a lot of pills. So this pill burden is a factor for him or her. For her. So, as a rheumatologist, you need to appreciate this fact. You need to make the patient understand that keeping those comorbidities in check are equally important as keeping the rheumatoid arthritis inactive. Because keeping your rheumatoid inactive will, in the long term, help manage your comorbidities as well. Because rheumatoid has shown in the research to affect inflammation on a global level in the body, and this inflammation can result and can accelerate coexisting comorbidities. So it's kind of, a vicious cycle that goes on. So you don't control rheumatoid, then you don't control hypertension, because you are not doing any favor to the patient by not achieving a good control. Similarly, a patient having multiple comorbidities need to be made aware of continuing the pills, although she might be feeling a bit overwhelmed by the number of pills she has to take every day. But it's very important to let her realize that once she achieves remission, this pill burden is going to definitely going to come down, and in the longer run, uh, it's the earlier you achieve this remission, the better it is, because you can't let rheumatoid control your life. You have to be in control of your life. That's very important. And coming to your second part, I think that is what you mentioned about, apart from comorbidity, you mentioned about something.
Yep.
Um,
Still,
the,
still experiencing symptoms, even though
right,
clinically we're supposed to be in
right,
remission.
right.
Kind
So
of what
these
causes that.
symptoms, yeah, so these symptoms have to be taken very carefully, and a good clinical history goes a long way. So you need to sit down with the patient. You need to assess the his her background, where she comes from, her socioeconomic background, her lifestyle. Everything needs to be considered. There are certain small factors which play a role in making these symptoms continue. Like one I have already mentioned, that is just made out of your mind, a feeling of sensation of pain just coming out of your mind. But now there are definite research showing that it has got its own mechanism, and it can coexist with rheumatoid. Also, there are certain factors in, especially in older age patients, like osteoarthritis. That is one degenerative condition which happens with age, where your usually affects the knees first, and then it can affect other joints like hips and ankles. So it can coexist in older patients with rheumatoid. So patients having pain in their knees, patients having pain in their hips or ankles might come to you and say, "Doctor, you say that I am in remission, but I am still having this pain." So you need to assess, you need to check those blood works, maybe have an imaging done of those joints, and then reassure her. So patients might not always get reassured by your word, but when they see some evidence, I'm sure they can appreciate that, yes, it is something else that causing the pain and not rheumatoid itself.
That was really
Yeah,
eye-opening for me in my
right,
rheumatoid arthritis journey because I was being told my medications were working and my disease is well controlled, but I was still in pain. And
right.
I then got the diagnosis of osteoarthritis and fibromyalgia. And it just kind of helped me understand what was going on. All right. So you've touched base a bit on this already as well, but early and effective treatment is important for those with rheumatoid arthritis wanting to reach remission. But for many of us, it takes time to find the right medication. It also takes a long time to even get diagnosed. Is there still hope for us?
Absolutely. So it's like you need to realize that rheumatoid arthritis is not a sprint. So in sprint, there's always that element of time that you need to start early to finish early. So it's a marathon, you know. So in marathon, even if you start a bit late, you can always catch up. So it's a journey. The destination is all not important out here, because as I said, it would be not fair to say that rheumatoid arthritis has a cure at this point of time. Science is progressing. Maybe will have a cure in the future, but right now what we are trying to achieve, the best part is of this rheumatoid treatment is remission. So the earlier you start and the better you stick to your treatment schedule, the better your chances are for a remission. Uh, in this journey, there will be ups and downs, because there are certain other factors which we don't all often take into account. There are bumps like stress in our personal lives, infections, injuries, which a rheumatologist has to face. A patient comes to you and say, "I have this surgical intervention planned, for which my doctor has said that you need to stop your medications for 1 month," and that becomes a challenge for us, because we need to then rearrange the medications likewise. So similarly, a patient having some sort of infection might have to stop these medications for a small while, for which we again might be having these patients coming to our clinic with a relapse. So every rheumatoid arthritis is just a part of life. There are certain other factors which often gets accounted for when you are with a patient for a long time. So it's like one of our very important adage in rheumatoid treatment is, does one size fits all? Right. So it is not something like that. So you need to sit down with the patient, understand those patients' preferences, understand those patients' uh, socioeconomic background, and then create a treatment schedule for them. So what might work best for you might not work best for the next patient. So it's very important that a patient comes to you regularly, keeps the appointments, and there are certain ways you can tell the patient that yes, these are the ways that you can adhere to your medications, like pill boxes, like some phone alarms. We have so many apps nowadays, health related apps, which they can download and install in their phone, which can remind them of to take their medications in time. And I think you know how important it is for patient advocacy groups to run in this aspect, that they need to be part of a larger group, they need to connect with each other, they need to read about success stories. Those are important to make them inspire that yes, this is a journey which definitely has a happy ending uh, for many. And one aspect of which I would like to touch is, by remission, some patients do have this question that yes, doctor, you said I will be in remission with good, right kind of treatment, but will I be in drug-free remission? That is some other aspect uh, which we need. I think a line about that would be good, because remission on medication is a form of remission. The best remission is remission without medication. Is that possible? Because that almost sounds like a cure. So remission without medications might sound like a cure. And studies have shown that if you can achieve remission for 1 year, out of those patients, when they are following some large study groups of rheumatoid patients globally, some have European patients, some have American patients, some Asian patients, about 10 to 20% of those patients do attain sustained drug-free remission without any medications. So why do this happen? That 10%, 20% patients achieve remission without any drugs or medications, while others have to depend on some sort of medication for being in remission or otherwise. That might be related to your genetics, that might be related to a deep understanding of your genes. There are differences in our genes itself. So science is developing to understand these differences, and hopefully we will be able to understand this disease more with the coming years, so that we can achieve a state of drug-free remission, and not only remission.
Mhm. When you mean drug-free remission, does that mean no drugs were used to reach remission and they use things like lifestyle and diet to achieve remission? Or is it they went off of their medication once they achieved remission?
Right. So a drug-free remission is also a stepwise procedure. So first step comes when a patient comes to you with swollen and tender joints to rheumatologist. The rheumatologist sits with the patient, works up a schedule, and then after a certain time frame, that patient reaches remission with some medications, be it some biologics, be it some what we call as DMARDs. So that's oral medications. So after that, the patient and the rheumatologist goes in regular consultations. What is in the guideline that you need to at least visit the rheumatologist every 3 months or 6 months. Once the patient has achieved that 1 year of remission, and it will be interesting for you to know that drug tapering or lowering down the drug doses are allowed only after 6 months of achieving a remission state. Right. So before 6 months, it is not advised that drastically reduce the dose of drugs. So once you start decreasing the dose, just don't, it's not a switch that is on and off. So you need to lower down the doses, you need to come down, you need to sit with the patient, see what is working for her. And once you are into the lowest possible dose of a particular medicine, and then also you see no flares. Flares are periods where patient starts experiencing those pains again. So now you discuss with the patient the pros and cons of stopping the drug entirely. I think that's what we are achieving right now, is shared decision making. It's very important for the patient to decide. It's not all the control should be at the hands of rheumatologist.
Mhm.
We should work as a team. The patient should be given this option that yes, you have achieved this. Yes, we are at this point where I can offer you that we can stop all of your drugs, but there's always this chance that you might be back with all the symptoms. But yes, there's also a 20-30% chance that you might not need any medicines for the rest of your life. If the patient is willing to take that risk, we go ahead and we can stop the drugs in a certain group of patients, and we can see where it takes us. So yes, there is a chance of stopping the drugs entirely, but to begin with, only lifestyle changes or only diet or only being healthy is not going to put you into remission. You definitely need some medications, but these are important as well. But once all the drugs are off, it is very important to tell the patients that please continue the lifestyle changes that has made us come to this point. And it will help, it will be your friend, that these changes which you have made in your life, maybe for that you don't will not be needing the drugs anymore. That just increases your chances of being in remission for the whole of your life without any drugs. So we need to communicate this to the patient.
Absolutely. So I have one last question that works perfectly now is what are some important questions that patients should be asking their rheumatologist?
Yeah, so I think the patient should be made aware of the symptoms, what we called in our literature as red flags, that these are the red flags that you should be noting. And once you are experiencing these red flags, these symptoms, you should be making an appointment with your rheumatologist. Uh, the patient should be very well made aware of the medications that they are taking, and any kind of untoward symptoms due to the medications itself, the patient needs to report that as well. So you need, whenever you are prescribing a medication, whether it be a biologic, whether it be a oral medicine, you need to make the patient understand the side effects of those medicines as well, so that they can understand that yes, this is not happening due to the disease, this is happening due to the medicine, and the doctor needs to change that. So whenever they are experiencing those, they need to come to back to the rheumatologist. And also, I think the patient needs to ask the rheumatologist that are there any newer drugs that is beneficial to me? Are there any new form of treatments that is beneficial to me? They need to engage with other forms of support groups. They need to meet their rehabilitation experts. So they need to give the same feedbacks to them also. And I think anything that they can't explain, they should reach out. That this is not usual. This is something unusual. This is something strange. Is it due to my rheumatoid? So we welcome all those queries from our patients.
Yep, there is
Yeah,
no dumb question to ask. They're
right.
all important.
Absolutely.
Right. Well, I've thoroughly enjoyed this interview. You've taught me a lot about remission today, even though I've done a number of these interviews. I love hearing the different perspectives from around the world. Is there anything else that you feel is important before we wrap up?
I think it's very important that, as I said, that it's a journey that a doctor and a patient takes when we are talking about rheumatoid, and it will going to have its own ups and downs, and we need to keep this element of hope, this faith, this trust, and the element of uh, uh, that awareness in the patient going. The patient should not feel confused at any point. The patient should not feel anxious at any point. And rheumatoid is just something that we should be able to deal with, and it should not control us at any point of time. And
Mhm.
as you said, no question is a dumb question. And we should be making the patients comfortable so that they can come up with any question. And that's it for now. And I guess anything else you can ask. you can always ask me. Yeah.
Well, thank you so much for this, taking your time to do this with me. I'm sure this is going to be teaching a lot of people valuable information. Hello,
So, yeah.
hello, my name is Eileen Davidson, and I'm here with a rheumatologist from India named Roy, and I'll let him explain himself a little bit more in a moment, but we're going to be talking about remission today. Roy, would you like to take the stage?
Yeah, hello, Eileen. Thanks for having me here. Talk about this very important aspect. So, I'm from India. So, I'm Debaditya Roy. I'm a budding rheumatologist. You can see I'm in my final year of residency in rheumatology from India. Currently, I'm based in Kolkata. That's in the eastern part of India, and where I'm doing my residency from institute called IPGMER.